Hi, this is Andrea Kane, and I'm here with you for HIT 120 Pharmacology, and we are now on week 6. This week we will be focusing on central nervous system drugs, specifically those talked about in chapters 16 through 21. We will be covering again unit objectives 9.3.1, 9.3.2, 9.4.1, and 9.4.2. We're actually covering central nervous system drugs this week and next week, but we're going to cover the bulk of them this week. Specifically, we're going to talk about drugs used in dementia, anxiolytic and hypnotic drugs, drugs used in mood disorders, antipsychotics, which are also known as neuroleptics, drugs used in Parkinson's disease, and anti-epileptic drugs, which are also known as anticonvulsant drugs. So talking about dementia. Dementia is an umbrella term used to describe a collection of brain diseases and their symptoms, which include memory loss, impaired judgment, personality changes, and an inability to perform daily activities. Excuse me. There are 5 types of dementia. Alzheimer's disease has the largest prevalence at 60 to 70% of all dementia cases. The next highest is vascular dementia. Just as it talks about vascular, it has to do with blood flow. So you can imagine they're also treating the vascular issues that are the underlying cause of the dementia in addition to the dementia. And that's 10 to 20% of dementia cases. Then you have frontotemporal dementia, and this has to do with deterioration in the frontal and temporal lobes of the brain, and it accounts for about 10% of dementia cases. Then there's Lewy body dementia, and that has to do with Lewy body protein deposits on nerve cells, which accounts for about 5% of dementia cases. And then the last category is other dementias. This includes dementias that occur because of Parkinson's disease, Huntington's disease, HIV, Creutzfeldt-Jakob disease, or Korsakoff syndrome. Drugs used in dementia. Well, when we start talking about what is dementia and what is happening, it has been noted that with dementia, there are changes in brain glutamate, dopamine, epinephrine, serotonin, and somatostatin. These changes cause a decrease in cholinergic neuron activity, and when there is a decrease in cholinergic neuron activity, it causes cell death or cell destruction, which means those brain cells die or are destroyed to a point where they cannot function. Treatment is focused on increasing acetylcholine, which makes sense because you need acetylcholine for that cholinergic neuron activity. None of the drugs available for dementia alter the underlying pathology. Please note that. None of the drugs available to treat dementia alter the underlying pathology. They only produce a marginal improvement in symptoms. There are only 2 major types of drugs that are used to treat dementia. One is cholinesterase inhibitors, and the other is NMDA antagonists. And when you think about the decrease in acetylcholine, that cholinergic neuron activity, causing brain cell death or destruction, you would want to inhibit any type of enzyme that breaks down acetylcholine. And that's where we're going to talk about these cholinesterase inhibitors. If you remember back, and this goes back a couple of weeks ago, when we first started talking about cholinergic and adrenergic drug agonists and antagonists, we talked about how acetylcholine is broken down by the enzyme acetylcholinesterase. These drugs block the metabolism of acetylcholine. That's why you want to use them, because they increase the concentration of acetylcholine at the cholinergic synapses. So going back here, if dementia means that you have a decrease in cholinergic neuron activity causing brain cell death or destruction, and the only way to treat it is to increase acetylcholine, then what you want to do is use these cholinesterase inhibitors because they increase the concentration of acetylcholine by blocking the metabolism of acetylcholine. So we learned this a few weeks ago that there are two types of cholinesterase inhibitors. We're only going to focus on type 1, which is reversible or water soluble. And what we want to talk about are Aricept and Exelon. Aricept and Exelon. They treat mild to moderate dementia. They help increase thinking and working memory. NMDA blockers decrease abnormal activity in the brain. They're a non-competitive antagonist. And what does that mean? A non-competitive antagonist, if you remember back a couple of weeks ago, these are the antagonists that they hang on and they do not let go. So remember that visual that we talked about where the key into the doorknob was the natural neurotransmitter. The pick that picked the lock and opened the door was an agonist. And the stick, or the big twig that stuffed in the door and prevented anything from getting into it, was an antagonist. And remember how we said that you can have a competitive antagonist and a non-competitive antagonist. These are non-competitive, meaning that you can't compete against them, that once they're in, they don't let go, and those receptors cannot be used. So what they do is they block glutamate, which is implicated in causing Alzheimer's disease. And that it's used to treat moderate or severe dementia. And Namenda is a brand name that you'll want to know. So going back to cholinesterase inhibitors, please make sure that you know the brand names of Aricept and Exelon and that they're used to treat mild to moderate dementia. And then NMDA blockers, you need to know Namenda as a brand name and that it's used to treat moderate to severe dementia. And that, again, this blocker decreases abnormal activity in the brain. So, quick quiz. What are the two types of drugs used to treat dementia? True or false, drugs used to treat dementia can improve the underlying pathology of the disease. Which drug name, and now I'm asking you for the brand name, is used on mild to moderate dementia? We studied 2. Which drug name is used on moderate to severe dementia? There's only 1. What happens to brain cells when there is a decrease in cholinergic neuron activity? What is the most common type of dementia? You know, there's 5. Which is the most common type? True or false? Vascular dementia patients are treated with dementia drugs as well as those that lower blood pressure, prevent blood clots, and or reduce cholesterol levels. I know you can get these. All right, tolerance. We need to stop at this point and go back and talk about tolerance and dependence. And we will talk about tolerance and dependence this week as well as next week when we're talking about opioids and opiates and anesthetics. But let's pause here in this week to talk about tolerance. Tolerance is a physiological state. So that's the first thing you need to focus on. It's a physiological state. It is characterized by a reduced drug effect with repeated use of the drug, meaning that whatever specific effect is, it's reduced with a repeated use of the drug, and higher doses of the drug are needed to produce the same effect. Reduced effectiveness of one effect. That's what tolerance is. Tolerance can be due to increased elimination of the drug, or it can be due to reduced effectiveness of drug receptor interaction. So let's talk about an example. If someone is on Valium and they experience less, and not really analgesia, but maybe less anxiety over time, but they will still have the same respiratory depression. That's tolerance. that one effect, analgesia or anxiety, is what is reduced over time, but they may have other effects from that drug, like respiratory depression, that continue at the same level. But because they experience less of one effect that impacts them, they may want higher and higher doses to get the same effect. Cross tolerance is someone who is tolerant to one drug in the same class will be tolerant to other drugs in the same class, but not to drugs in other classes. So example, someone who is on Valium who develops tolerance to the sedative effect will also develop that same sedative effect tolerance if they are switched to Ativan, because Ativan and Valium are in the same drug class. So if someone develops tolerance just to one effect, like the sedative effect, then if they are taken off that drug and put on another one in the same drug class, they will have the same reaction, the same tolerance to the same effect. Hopefully that makes sense. Dependence. Dependence is characterized by signs and symptoms of withdrawal when drug levels fall. Dependence can be physical and or psychological, depending on the withdrawal shown. So a couple things to think about here. Dependence has to have some type of withdrawal. When the drug levels fall, in order to say someone is dependent, they have to have signs and symptoms of withdrawal when that drug level falls. And the dependence can be physical, psychological, or both. Now, we talked about tolerance. Tolerance is physiological only, physical only. That's something you need to know about tolerance. Dependence is physical or psychological or both. And with dependence, you have to have signs and symptoms of withdrawal. So let's talk about an example. If someone's dependent on a barbiturate, and we'll just pick, there's one down there, Butasol. If someone's dependent on a barbiturate like Butasol, when they experience withdrawal, it may be characterized by nausea, vomiting, hypotension, seizures, anxiety, and psychosis. In that characterization, do you see physical and psychological withdrawal symptoms? Yes. So we can say that when they experience withdrawal, if we see physical or psychological or both signs and symptoms when the drug level falls, that they are dependent. Cross-dependence is very similar to cross-tolerance. So let's talk about cross-dependence. If someone is dependent on Seconal, and if they are ever removed from it and put on another barbiturate like Butasol, they will likely become dependent on it as well. That's what cross-dependence is. If it's in the same drug class and they've already become dependent on one drug in that drug class, odds are they will likely become dependent on another drug in that same drug class. This last statement is key. Cross-dependence occurs between all CNS sedatives, including barbiturates, benzodiazepines, and ethanol. Meaning that if you become dependent on a barbiturate or a benzodiazepine, you have a very high chance of also becoming dependent on alcohol. And that is one of the reasons why they strongly urge you not to drink any alcoholic beverages if you take a barbiturate or a benzodiazepine. And we'll talk a little bit more about that when it comes to talking about benzodiazepines, because they have a very ugly relationship when it comes to alcohol. All right, so quick quiz. What is tolerance? True or false, can tolerance be both physical and psychological? What are two possible explanations for how tolerance develops? True or false, tolerance typically involves all effects of that drug. What is cross-tolerance? True or false, cross-tolerance typically involves only drugs within the same class. What is dependence? True or false, dependence can be both physical and psychological. What is cross-dependence? And true or false, cross-dependence and cross-tolerance are similar. I know you will get all of these. Moving on to anxiolytic and hypnotic drugs. The first thing you need to know is we need to talk about what is a sedative and what is a hypnotic, because they look like they mean the opposite. A sedative induces a mild CNS depression for mental and physical calmness without inducing sleep. A sedative does not induce sleep. It reduces anxiety without inducing sleep. Please make sure that when you see the word sedative, in your mind, you're thinking mental physical calmness, anxiety reduction, does not induce sleep. A hypnotic, on the other hand, also induces a mild CNS depression, but that depression does induce or maintain sleep. So make sure you know the two of them. This next piece, focusing on just barbiturates and benzodiazepines, there is a link here that I think it's well worth looking at and taking your time. I'm not going to do it during this lecture video, but I will tell you that that information I think will be very helpful to you to understand barbiturates and benzodiazepines, and will help you prepare for your quiz. So let's take some information from that website. It's not everything that's there, but it's some of it. Barbiturates are known as barbs. They're a type of drug used to treat anxiety, seizures, migraines, and alcohol poisoning. Because they are highly addictive and can be extremely dangerous if mismanaged, they are no longer used to treat anxiety. It's very rare that they're used to treat anxiety. Where they're dangerous is they cause severe respiratory depression, and we'll see that in another slide here in the near-term future. Benzodiazepines, sometimes called benzos, are a class of psychoactive drugs. They are used to treat alcohol dependence, seizures, anxiety disorders, panic, agitation, and insomnia. Some types of barbiturates are listed here. Notice that almost all of them have barbital at the end. That is one way you can identify whether or not it's a barbiturate, is to look at the end of the generic name and see if it's barbital. Benzodiazepines, they usually end in PAM or LAM. The ones that you need to know are the brand names, and those are actually the ones first, not second. So the brand names you need to know are Ativan, Xanax, Valium, Ambien, Dalmane, and Klonopin. What are some withdrawal symptoms of barbs and benzos? Panic attacks, insomnia, cravings, tremors, confusion, seizures, coma, and death. So it's very serious. These are patients that need to be managed medically in an acute care facility, meaning doctors, meaning crash carts, meaning very close observation, and they have to be slowly taken off of the drug, and they're taken off the drug, but all of their side effects, their withdrawal symptoms, have to be managed very carefully with other drugs. I have worked in healthcare organizations that have had detox units, inpatient detox units, where patients check themselves in, or they can be court-ordered to check in, and they're withdrawn. They have obviously taken their last dose, and then it's managed from there. And sometimes in a hospital detox setting like that, if the amount of barbiturate or benzodiazepine is high, they will have to give the patient some of that and slowly back them down. You can get hooked very fast on benzos and barbs because both substances are habit forming, addictive. Tolerance is built up fast, so the person needs more and more to achieve the same effect. When the person lowers the dose or stops taking the drug, that's when they experience withdrawal. Between the two, barbiturates are much more addictive and dangerous than benzodiazepines, but both cause dependence and both have unpleasant withdrawal symptoms. So one of the on this slide, what I want you to take away from this is the middle section. So if you're looking at here, it says high doses are fatal. This has to do with barbiturates. If you look at the blue line, the bright blue line, it's the straight one that goes up. This is how barbiturates act. At a low dose, they cause relief of anxiety. They cause some sedation, some hypnosis, where there's a little bit of sleepiness there. But with barbiturates, they keep on going. They hit a point where they cause anesthesia, and the respiratory depression can get so bad it can end up in coma or death. That is why barbiturates are so dangerous. Benzodiazepines are the red line. And at a low dose, obviously, you can see that they help with anxiety, they help with sedation, they help with that sleep, but they veer off. They never hit the point of anesthesia, coma, or death. So in that sense, benzodiazepines are safer to use for anxiety, sedation, and sleep than barbiturates are. And so, as they point out down here at the bottom, barbiturates now are pretty much used for like pre-op sedation, seizures, induction and maintenance of anesthesia because it's short-lasting. And this is just some interesting statistics about barbiturates. It's amazing how dangerous they are, and yet they continue to be prescribed. Over 19 million prescriptions for patients every year. And then this talks about some common signs of addiction. Now, benzodiazepines. Remember, we looked at this piece here at the bottom earlier about how barbiturates were so dangerous because they headed straight up at higher doses into anesthesia and death. What I want to point out on this slide is that benzos by themselves do not produce anesthesia, cause fatalities. They don't produce anesthesia or cause fatalities, but they lower the lethal dose of other CNS depressants like alcohol. So when you have benzodiazepines, they in and of themselves are not going to cause anesthesia, coma, or death. But what they do is when you mix them with another CNS depressant, such as alcohol, the lethal dose of what you would need is so much less. And that's why you have people who are on benzodiazepines and they have some other CNS depressant and they die. So that is what that is about. I thought this slide was very interesting. The ideal hypnotic to help you sleep is right here in this time frame of blue. The ideal anxiolytic, which helps with anxiety, is here in this green square. And down here at the bottom, you can see the red is benzodiazepines. You can see why they are ideal for use with either a need for sleep or a need to reduce anxiety, because the way that they work, it really covers both. And oftentimes people who are anxious do have trouble sleeping. Okay, so talking about benzodiazepines, there are risks and limitations, and I thought this was helpful information. Also, if you have the time, this is not a part of your quiz or anything like that, but I happened to go out and read this article, and it was absolutely fascinating and great information. So if this is something that you would be interested in, I strongly encourage you to click the link and go out and take a look at it. because it's just very well done. So quick quiz questions. What is a sedative and what does it do? What is a hypnotic and what does it do? What are the two major types of anxiolytic hypnotic drugs? And now let's talk about barbs or benzos. Which type of drug is the most highly addictive? Which one has 4 of the most common drugs prescribed in the US? Which one no longer is recommended to use for anxiety because of tolerance and risk of increased dose causing coma or death? Which one is used for anxiety or insomnia because it does not cause coma or death? And which one is dangerous because it lowers the fatal dose of other CNS depressants like alcohol if taken together? So let's move on to mood disorders. There are essentially 3 mood disorders, but we're only going to talk about the first 2. And that's depressive mood disorder and bipolar mood disorder. Etiologic is substance-induced mood disorder and mood disorder due to general medical condition. Those are small fractions of mood disorders, and those are typically managed on a very short-term basis, and there aren't a whole lot of complications and those types of things. So again, we're going to focus on depressive mood disorder and bipolar mood disorder. Some risk factors for psychiatric disorders. I thought this was interesting. They include unemployment, displacement, peer rejection, social disadvantage, lack of education, transport, housing, war, poor nutrition, violence and delinquency, and work stress. And you can see how any of those, not to mention several of those, absolutely could cause just such pressure, stress, and misery, unhappiness, that a mood disorder could very likely result. Under depressive, there are a couple of disorders. You'll hear about major depressive disorder, or MDD, or dysthymic disorder. Under bipolar, there's bipolar 1, bipolar 2, and cyclothymic disorder. And there's actually up to 5 types of bipolar that you may see listed depending on where you go for your information. I'm not going to get down into the weeds with that. I'm just going to stick with the major categories of depressive and bipolar. But would encourage you that if this is an area of interest, to go out and continue to research. So, drugs used in mood disorders. The goal of depressive disorder treatment is to reduce the frequency and severity of depressive moods, to increase the concentration of norepinephrine or serotonin, usually by inhibiting the reuptake of neurotransmitters. There are 5 drug groups that are used to treat depressive disorders: SSRIs, SNRIs, heterocyclics and TCAs, MAOIs, and then there's a group that's basically other. And I will tell you that heterocyclics, TCAs, MOAIs, and other are very rarely used. They are typically used if nothing else works, because they tend to have stronger, worse side effects. So in terms of depressive disorder treatments, you're going to most of the time hear about SSRIs and SNRIs. Just keep that in mind. The goal of bipolar disorder treatment is to reduce the frequency and severity of depressive and manic mood fluctuations. The drug mechanisms are pretty much unknown, and they have specific drugs that they use, not usually specific groups. We're going to talk about a couple of specific drugs. We will talk about the fact that there are specific drugs from anticonvulsants and antipsychotics that are also used with the specific drugs that treat bipolar disorder, but they don't use they don't have groups in the same way that depressive disorder drug treatment does. So keep in mind those differences. Common types of depressive disorders. There's major depressive disorder, which shows this person with a thundercloud, just kind of constant and intense. Then there's persistent depressive disorder that lasts for a long time. There's bipolar depression, because that can be part of what's happening in the bipolar disorder process. postpartum depression, premenstrual dysphoric disorder. And then one thing that we see here in the Midwest often is seasonal affective disorder with all those gray, cold days. And then there's atypical depression. So let's talk about those SSRIs and the SNRIs. We'll begin with the SSRIs. SSRI stands for serotonin specific reuptake inhibitor. Serotonin is inhibited, but norepinephrine and dopamine are not. One thing you will find about drugs used for depressive mood disorders is that they take several weeks to work. They don't just jump in automatically. They can take 2 to 3 to 4 to 5 weeks before they start working. So getting back to SSRIs, they take several weeks to work. None are better than another, and they do have sometimes, severe withdrawal symptoms if they're stopped abruptly. Sexual dysfunction can be a side effect, and they are also used to treat eating disorders, panic disorder, OCD, and borderline personality disorder. The examples I want you to know are the brand names that are in bold in parentheses: Paxil, Prozac, Zoloft, Celexa, and Lexapro. SNRIs are serotonin norepinephrine reuptake inhibitors. So serotonin and norepinephrine are inhibited, but dopamine is not. Thought to have fewer but similar side effects than SSRIs, they can they can cause a dose-dependent increase in blood pressure. They're also used to treat diabetic neuropathy, fibromyalgia, and ADHD. Examples you need to know are the brand names that are in bold in parentheses: Strattera, Pristiq, Cymbalta, and Effexor. So now we get into the ones that are not often used for depression. Typically, they're used for other things. You have your heterocyclic TCAs. That's where serotonin and norepinephrine are blocked, but not dopamine. Again, they take a while to be effective. They have side effects. They aren't used unless nothing else works, and they are also used to treat other things. MAOIs are called monoamine oxidase inhibitors. This increases all three: serotonin, norepinephrine, dopamine, by inhibiting their degradation. So by keeping them going, it increases their concentration. Again, rarely used as an antidepressant now. MAOIs have extensive food-drug interactions from what's called increased tyramine, and it can cause severe hypertension and cardiac arrhythmia that it can even lead to death. So it's only used if nothing else works. MAOIs are also used to treat Parkinson's disease, but again, this is a real risky one because there are all sorts of things that you can't eat, and you've got to be aware of how they interact with other drugs and that type of thing. Bipolar syndrome. This is where I talked about that there are all sorts of different types of bipolar syndrome. You have bipolar type 1, type 2, you have rapid cycling, mixed states, and cyclothymic disorder. The primary drug that is used to treat bipolar disorder is lithium. It is a drug that has been used for a long, long time, and they have found that it's best for controlling mania. The mechanism of how it works is unknown. It is also used off-label with antidepressants, sometimes to help boost the antidepressant impact. It does have side effects. In addition to lithium, there are select drugs from the anticonvulsant family and the antipsychotic drug family that are also used. So let's do some quick quiz questions. What are the 2 types of major mood disorders? How do antidepressants usually work? What do they increase? And how do they do that? That's going to be neurotransmitters are what they increase. And how do they do that? They do it sometimes by blocking. They do it sometimes by increasing the concentration. They do that by acting as an antagonist or an inhibitor, those types of things. There are 5 types of antidepressants. What are they? List at least 3 brand names of SSRIs. List at least 3 brand names of SNRIs. Those are the ones that are bold and in parentheses. Why are heterocyclics, TCAs, and MOAIs rarely used? When are they used? How do bipolar drugs usually work? What do they increase, and how do they do that? Name the main drug used to treat a bipolar mood disorder, especially the mania phase. And I want to go back to number 7 here. How do bipolar drugs usually work? The truth is, if you didn't catch that back here, they don't know how they work. Okay, so don't try and go out and try and see what do they increase, how do they do that. We just don't know. But I put it on here because you need to understand that the mechanism is not known. Skipping ahead to number 9, what other types of drugs are used with lithium to treat bipolar disorder? So moving on to antipsychotics or neuroleptics. What is psychosis? Psychosis distorts a person's perceptions and thoughts through hallucinations and delusions. Warning signs include paranoia, social withdrawal, trouble concentrating, and difficulty communicating. There are many types of psychotic disorders. They include schizophrenia, which is the most common, schizoaffective disorder, schizophreniform disorder, delusional disorder, brief psychotic disorder, substance-induced psychotic disorder, bipolar disorder, postpartum psychosis, severe depression, and psychosis suicide. Psychosis and psychotic disorders are typically caused by chemical changes in the brain. It can be caused by trauma, but that is rarely considered to be the sole cause. Acute stress can provoke a psychotic break, especially when it occurs alongside a medical condition or substance abuse situation. Unless a person has an underlying disorder, these episodes quickly resolve and rarely recur. Psychotic episodes triggered by substance use and stress rarely develop into chronic conditions like schizophrenia. While the specific brain mechanisms behind schizophrenia are disputed, research suggests it's linked to atypical patterns of communication between the prefrontal cortex and the parts of the brain that control emotion and memory. So there's some type of miscommunication happening between the part of the brain that controls judgment and planning and the part of the brain that controls emotion and memory. Some statistics about psychosis show that while the disorders are severe, they are treatable. And it just lists those for you. So let's talk about these antipsychotic or neuroleptic drugs. They are not curative. Just like with dementia, they try and permit the patient to function more normally, but they can't cure whatever the underlying issue is. Antipsychotics are all dopamine blockers, alpha, which is norepinephrine blockers, muscarinic, which is cholinergic antagonists, or histamine, which is epinephrine antagonists. They're one of those types. And not that you need to know that, but it's helpful to understand that they all fall into one of those types based on their how they were created. There are first-generation antipsychotics. They're also known as typical or traditional antipsychotics. There are now second-generation antipsychotics. These are known as atypical or newer antipsychotics. The first-generation ones typically have neurological side effects. The second-generation ones typically have metabolic side effects. They can still have neurological ones, but it's not nearly as common as it is for first-generation drugs, so try and keep that in mind. One thing you need to know is that first-generation or second-generation antipsychotic drugs can cause a condition known as neuroleptic malignant syndrome. This is a life-threatening, potentially fatal, idiosyncratic reaction to this antipsychotic drug that someone has taken. It's hard to predict who would get this. It's usually when someone has been on high doses of the more potent agents for a longer period of time. It's characterized by a high fever, altered mental status, muscle rigidity, and autonomic dysfunction, meaning heart arrhythmias, tachypnea, which is difficulty breathing or fast breathing, and hypotension or hypertension, one or the other on an extreme. It resembles a very severe form of Parkinsonism, not Parkinson's disease, but Parkinsonism, and can persist for even up to a week after the drug is stopped. So even if someone is diagnosed with this and they stop giving them the drug, this syndrome can last even for up to a week after that drug is stopped because it's in their system and it has to cycle out. So anyone who is on an antipsychotic, if they're not, they need to be watched carefully for this, especially if they are on a high dose of what is considered a more potent agent. Okay, so let's talk about the typical antipsychotics or the first generation ones. They all have pretty much equal efficacy. They only vary in potency and side effects. They often produce neurological side effects such as Parkinsonism, akathisia, and tardive dyskinesia, and it's defined there. Just know that they may produce first generation, they can often do produce neurological side effects. And the one you need to know is a brand name. It's bold in parentheses here, Haldol. Second generation, these are serotonin dopamine antagonists. They reduce both the positive and negative symptoms of schizophrenia. Positive symptoms include hallucinations, delusions, disordered thoughts, and agitation. Negative symptoms mean withdrawal, flat affect, ahedonia, which means basically you have pleasure in nothing. Nothing can make you happy, nothing can make you feel good, and catatonia. They rarely produce neurological side effects like the first generation drugs, but they can produce metabolic side effects such as weight gain, prolactin changes, heart function. The examples you need to know are bold, and in parentheses, they include Abilify, Risperdal, Seroquel, and Zyprexa. Some quick quiz questions. List at least 4 types of psychotic disorders. How are psychotic disorders thought to be caused? True or false, antipsychotic drugs can cure the disorder. What is neuroleptic malignant syndrome and how is it caused? True or false, first-generation drugs can have neurological side effects. Name one first-generation drug, and we studied that and only have one, the brand name, again, bolded in parentheses. Which 2 neurotransmitters do second-generation drugs target as an antagonist? True or false, second-generation drugs can have metabolic side effects. And last but not least, name at least 3 brand names of second-generation drugs. And those are the bold in parentheses. All right, we're hanging there. We're only 2 chapters left. If you get a chance, you may want to go out to the Michael J. Fox Foundation website and take a look around. There's a lot of really good information about Parkinson's disease. And that's where I got this infographic that I'm sharing with you. It affects 1 in 100 people over the age of 60. 60,000 new cases will be diagnosed this year alone. It's caused by the death of brain cells. We talked about how that is integrated into, if you lose those brain cells, how that can lead to symptoms of dementia. And that's where it talks about lesser known symptoms of Parkinson's include depression, apathy, fatigue, and dementia. And then you can read through the rest of this. All right, what are some early warning signs of Parkinson's disease? This talks about how would you identify that in someone. Let's talk about the drugs used in Parkinson's disease. Again, because it has to do with loss of dopamine, Parkinson's equals that loss of dopamine, You want to focus on dopamine replacement, dopamine agonist to increase that dopamine, or an anticholinergic therapy. So those are the three types of Parkinson's disease drugs: dopamine replacement, dopamine agonist, or anticholinergic. And there are, and I've listed all of these for you. You really need to know all 6 of these drug names. Levodopa and carbidopa are generic names. Mirapex and Requip are brand names. Cogentin and Artane are brand names. Those 6 drugs are used to treat Parkinson's disease. Okay, we are on to our last chapter, chapter 21. We're going to talk about epilepsy and seizures. There are 2 main types of seizures. There's the generalized seizure that involves the entire brain, and a focal or partial seizure that begins in one brain area and affects only one part of the brain. It can turn into a generalized seizure. And I thought this was a really helpful graphic because at the top you see a normal EEG and how the brain's waves look in a normal situation. Then you can go down and see when someone's having a partial seizure and they do an EEG, what those brain waves look like, as opposed to a generalized seizure and what the EEG looks like when that's happening. There are many conditions that can affect the brain and trigger epilepsy or seizures. These include brain injury, either before or after death. Sometimes someone can be in a car accident, have a severe head injury, and it unfortunately leaves them with seizures. Brain tumors, infections like meningitis and encephalitis. There are some genetic conditions that cause epilepsy. There are sometimes abnormal blood vessels in the brain that can trigger seizures, metabolic or chemical imbalance issues, immune disorders, and lead poisoning. In most people with epilepsy, the specific cause is unknown. So what are the drugs that are used to treat seizures or seizure disorder, which is known as epilepsy? These are, and I am going to ask you to know them, they're all brand names: Depakote, Tegretol, Topamax, Lamictal, and Neurontin. Those are all used. They do have some side effects, and they are used to treat other things, but just know those brand names. So last quick quiz question for this week. What are the 3 types of drugs used to treat Parkinson's disease? Think dopamine, and anticholinergic. Name the generic or brand of at least 2 drugs that are used to treat Parkinson's disease. What is the difference between a generalized seizure and a partial seizure? And name at least 3 brand names of anticonvulsant drugs. All of your quiz questions for this week are pulled from these quick quiz questions. So if you can answer them, then you will do just fine on the quiz. I have shifted to that to try and help you prepare so that you're not wondering exactly what is in there. So if you know the information to all the quick quiz questions, you will be well prepared for your quiz. I hope you're doing well. I hope you're staying warm, and look forward to talking to you next week about narcotics, general anesthetics, and local anesthetics. Take care.